in a while.
Okay.
And you can take the, we can also, in a while.
Okay.
And you can take the, you can also.
Okay, hello everybody. Thanks for being here with us in this project, eCare for PD. This is an Erasmus Plus project that started last year and will finish next year in February. And the main purpose, as you may know, is to share good practice related with patients, caregivers, and health and care professionals, where we try to make their quality of life better through the use of some services using technology, for instance. So this is the fourth good practice exchange meeting that we have been holding till now. Spain, Belgium, Greece, and now Serbia is going to participate in this exchange. So it is a pleasure for us that you came, and I think Pablo from the Serbian Brain Council is going to present the people that is going to participate, sharing their knowledge with us. Pablo, if you want.
Okay, thank you. Thank you, Maestra, for the introduction. We are Serbian Brain Council. I'm currently president of the Brain Council of Serbia, and this is was our task to prepare this fourth good practice meeting, and we managed to organize 3 speakers for today. 2 are actually professionals in the medical field. Gorica Marić, assistant professor from the medical faculty of Belgrade, will talk about quality of life of Parkinson's disease patients, of course, in our Serbian environment. Later, Vladana Marković, assistant professor, also medical faculty of Belgrade, will talk about the research, because we have actually a quite strong group of researchers on Parkinson's disease. She will talk what is the benefit for patients of this research. And in the middle, actually, of our agenda, we have a very important, I would say, talk. It's always the most important to hear people from the field, really from the battlefield of the disease, and a caregiver. We have here Mr. Ivan Brankovan, who is actually husband of a patient, and they prepared together, in fact, a presentation, a talk. Ivan told me that he will have to read it because he doesn't want to learn it by heart or forget some parts. So I've seen the text. It's very informative and interesting and important. So that's what we have prepared for today.
Okay, thank you, Pablo. So maybe, maybe we could start with Gorica Marić.
Yes, thank you. Okay, I will share my slides. Can you see it?
Yes.
Yes. Okay, then I can start. Once again, hello to everyone, and I'm very happy to have this opportunity to be part of the meeting. And it is great pleasure and honor for me to present you results of quality of life in Serbian patients with Parkinson's disease. Sorry, I just want to. Okay. So According to the Global Burden of Disease, Injuries, and Risk Factors in 2016, Parkinson's disease contributes with 3.4% of disability-adjusted life years and with 2.5% of deaths to overall burden of neurological disorders. And its contribution to daily burden increases with age in both sexes. Do you maybe know how can I change slides without with mouse or something like that? Okay, now it's working, sorry. As a chronic progressive condition with such various mixture of motor and non-motor features, different aspects of daily life in persons with Parkinson's disease are affected. And it has been shown that for patients, motor symptoms are a rather poor indicator of quality of life, and that non-motor symptoms are a major additional contributor. When we want to assess quality of life in some population, we need instruments. So this slide summarizes it has 4 generic questionnaires used for assessing quality of life in persons with Parkinson's disease and 5 disease-specific questionnaires. The 2 mostly used generic questionnaires for Parkinson's disease population are Euro Quality of Life 5 Dimensions and SF Quality of Life 36, containing 36 items. While the most specific, mostly used disease-specific questionnaire in this population is Parkinson's disease questionnaire containing 39. This is the same table. The first paper on quality of life in persons with Parkinson's disease in our country was published in 2009. It was conducted at the Clinic of Neurology at the University Clinical Center of Serbia in Belgrade. And the primary aim of this study was to validate the Serbian version of Parkinson's disease questionnaire and to detect or to identify significant contributors to quality of life in our patients with Parkinson's disease. So I comprised 102 patients with Parkinson's disease. Then we used back depression inventory to identify level of depressive symptoms in these patients, and the quality of life was assessed with the specific Parkinson's disease questionnaire and also with generic questionnaire SF36. Descriptive statistics for the Parkinson's disease questionnaire, summary index, and subscale scores are presented in this table too. And as you can see, no gender-specific differences in Parkinson's disease questionnaire scale scores were found. Also, there was no evidence for Parkinson's disease summary index difference between patients and the disease onset before and after age of 50 years. When the mean scores of Parkinson's disease questionnaire summary index and subscales from that questionnaire were analyzed in relation to HENIAR staging, obtained results were as expected. So the more severe Parkinson's disease, according to the HENIAR stage score, the lower quality of life. Emotional well-being, as you can see on this slide, was the only exception. And group differences in perceived stigma were also marginal significance. Parkinson's disease questionnaire summary index showed some significant strong correlation. So it significantly correlated with two summary SF-36 composite scores, physical health composite and mental health composite. Also, it significantly correlated with the Beck Depression Inventory score, total UPDRC motor score, and with the duration of disease. Having in mind that falling, as well as fear of falling, have profound impact on the outcomes of Parkinson's disease patients, including as well decline in their quality of life, a study investigating the relationship between falling and health-related quality of life was conducted in Serbian Parkinson's disease patients. Authors of this article hypothesized that Parkinson's disease patients with lower health-related quality of life at baseline would have greater chances for falling in the subsequent follow-up period. For the aim of this study, combining both cross-sectional study design and cohort design, it means prospective one-year study, was to assess what is potential predictive value of domains of health-related quality of life obtained at baseline evaluation in the future occurrence of falls in Parkinson's disease patients over the course of 1 year period of follow-up. So the total of 300 PD patients were recruited at the Clinic of Neurology at the University Clinical Center of Serbia in Belgrade at the Department of Movement Disorders. In the cross-sectional part of the study, on 300 PD patients, all domains of the SF-36 questionnaire, with the exception of raw emotional, were significantly lower among fallers in comparison to non-fallers, as you can see in this page. Raw physical composite score and the overall health-related quality of life score, as measured by the means of SF-36 questionnaire, were found to be significantly associated with falling within 1 year of follow-up in this cohort of PD patients. And this indicates that patients who rated their own functioning as poor had a higher risk of falls course of 1 year of the subsequent follow-up when they were compared to those who rated these 36 domains better. Next year, in 2016, the same research group published another article, which aim was to assess whether various domains related to health-related quality of life could be predictive of recurrent falls among persons with Parkinson's disease during a 1 year follow-up. And a total of 120 consecutive persons with Parkinson's disease who had denied falling in preceding 6 months were recruited at regular checkups, again at the Clinic of Neurology at the University Clinical Center in Serbia. And at baseline, all study participants were clinically assessed. Their health-related quality of life was evaluated using one generic questionnaire, SF-36, and also participants were prospectively followed for 1 year, and occurrence of falls during that period was registered. After the adjustment for age, gender, then disease duration, levodopa dosage, HENIAR stage, as well as their Unified Parkinson's Disease Rating Scale, as well as Hamilton Depression Rating Scale, and taking into account also Hamilton Anxiety Rating Scales. Our authors identified SF36 item short form health survey domains of role, physical, and vitality as being associated with recurrent falls of persons with Parkinson's disease within 1 year of follow-up period. And that would be all from me. Thank you very much for your attention.
That's great, Orica. Thank you very much. It was a really interesting presentation.
Thank you.
Yeah, to know about the quality of life of patients there in Serbia. So maybe we can proceed with the following speakers and leave some comments or questions at the end, if that's okay with you.
Oh, yes, of course. Thank you very much.
Yes, so thanks again. And now it will be the turn of Ivan Brankovan. I don't know if, yes, I can see he's connected. Hello, Ivan.
Yes, I'm here, but we have some problems.
No, it's okay. They disconnect us.
Okay.
No,
We can hear
Maitza,
you.
just put on the video for the guest.
Because it's written that we cannot start the video because the host stopped it.
Yeah. So Maitza, just let us in, or is it Spiros?
Who stopped our video?
Spiros, yeah.
Wait, cool.
Okay.
Now we are here, okay?
You're back. Thank you so much. Yeah, so
Just 1 second, so we are here, cool. Hello.
Okay,
Word to Ivan Brankovan, introduce yourself, please.
hello to everyone. My name is Ivan Brankovan, and I'm husband of a PD patient for about, I don't know, 16, 17 years. And I would like to give you a kind of overview of the Association of Parkinson's Disease Patients, which is established in Belgrade. Belgrade Association of PD Patients were founded in 2015 on the initiative of a few patients with PD. Exceptional assistance in the formation and operation of the association was provided by Professor Vladimir Kostić, who at the time was the director of the neurology clinic in Belgrade, and Professor Marina Svetel, who is a specialist for Parkinson's disease. Cooperation between the newly founded association and the medical team from the neurology clinic was excellent. Excellent opportunity for us and our families to raise together the healthcare professionals' awareness about this disease and about social, economic, and cultural impact it has on PD patient, their family, and the caregivers. We all together aim to make the quality of life of patients as high as possible with the help of better information in the public about this spreading disease. Parkinson's disease, often shrouded in mystery, is a challenge that many people face every day. Although it has become known to the general public, many facts about this neurological disease remain unknown to the general population, and maybe to some of the medical professionals. While symptoms and experiences may vary from person to person, there is a common thread: the search for understanding and relief. Beyond its medical importance, understanding this disease helps patients, their families, and caregivers to cope with the challenges it brings. Also, raising awareness and educating the public are key to providing support and understanding to people living with Parkinson's disease. Because very often we don't meet with meaning the patients and caregivers, are not meeting with understanding from various sides. Serbian portal stethoscope.rs, one of the most popular medical portals in Serbia, announced in 2018 that the Association of Parkinson's Disease Patients is the most active organization in our region in raising public awareness about this disease. According to the same source, in 2018, 100,000 people in Serbia read texts about Parkinson's disease, About 3,500 questions were received by that site on the topic of Parkinson's disease. The term Parkinson's disease was searched on Google in Serbia approximately 6,600 times in that year. These figures indicate the necessity for accurate and reliable information because the information is lacking in Serbia. In Serbia, there are over 20,000 Parkinson's disease patients and an unknown number of caregivers. The unknown number is because we don't have any information about the families of the patients. The patients are usually seeing the doctor. The doctors are diagnosing Parkinson's, and then we don't have any information about caregivers. Although everyone struggles with the same disease, the problems they encounter can be very different. Different meaning physical differences, the environment differences, and all other differences depending where how the disease progressed with that individual, where is he physically located, in what area of Serbia he or she lives. In order to activate a great number of members, the association sent letters and brochures to all relevant doctors in all health centers and hospitals in Serbia with information that the association was formed and that as many PD patients as possible should be informed about it so that they can join, that they can contribute in whatever way they can. Or that they participate in the activities of the association. The website, a website was and Facebook page were activated. Our members also put up posters at neurology clinic and conferences of neurologists. A certain number of patients who were in a better condition were assigned to represent the association in communication with institutions of the health systems of the Republic and with other entities which can achieve a better in order to achieve better status, expand the rights of PD patients, and achieve that that some modern treatments are made available to the patients. Very soon, the association has become a place where PD patients can find either advice to patients on coping with everyday life, sometimes a word of comfort, help in addressing and possibly solving the problems which they have. The association also organizes activities which would help them maintain physical and intellectual functions. In the first place, movement, balance, speech, etc. Information about their rights, practical information. For example, what kind of help and assistance can be expected from the health system, where to find medicines that are difficult to find at the moment, etc. Or exchanging information. Maybe some patients have surplus of some medicines that are needed by others. Raising awareness about PD in society and the specific problems that patients and their families was attempted through organization of charity gatherings and events with the aim of collecting funds for the work of the association and helping the members with low means. Developing the need for socializing physical and mental activity. Participating in various cultural events, sales, exhibitions of handicrafts of association members. In order to draw attention to the association and to obtain some funds, association organized Parkinson's Champion during the Belgrade Marathon event. I cannot remember the year. When was that? Our members took part in several local TV shows and which were dedicated to Parkinson's disease. Every year on the international, some of the shows are available on still available on the internet on YouTube. Every year on the International Day of Parkinson's Disease, a charity concert was held in the National Theater in Belgrade. The president of the then president of the association, Jelena Savic, played the main role in the organization of these concerts. COVID and the lockdown have put an end to this practice. The association at one period of time had an exercise room or area where the members could have physical exercises under qualified supervision. This was free for the members. We paid a certain amount to the lady who was supervising and composing the exercises so that they fit Parkinson's patients, and maybe sometimes they were individual. This practice was discontinued due to COVID lockdown. It was not initiated again because of the special COVID circumstances, the death of the president of the association and lack of funds. And it was not, the COVID circumstances also initiated the exercises via Skype or Zoom or whatever was available to that, but that proved to be quite difficult because the patients were not able to organize themselves, their cell phones or laptops to be able to communicate with a person who is conducting those exercises. The main problem we see at the moment is obtaining the funds for further activities. The membership fees are not sufficient as a sole income of the association. And besides, some of the patients have very low means, so even the fees are not possible for them to take. Now, about caregiver's position. The position of caregivers depends primarily on the financial situation, age, and whether the patient or the caregiver is employed or not. Obviously, better financial situation is enabling caregivers to devote more time to the patient. And if the caregiver is employed, that would also take a lot of time from the patient as well. But also it depends on the stage of patient illness. In our case, in the case of my wife and me, in the first 15 years from the discovery of the disease, the involvement of the caregiver or myself or the patient's family was not big because she was, my wife was fairly independent in everyday life and everyday activities, although she was retired at that time. But as the disease progresses and thus the age of both the patient and the caregiver are increasing, the demands become greater and more difficult. A better financial situation enables the use of a greater number of medicines and supplements, which are not funded by the healthcare system. We are using a lot of them because our finances are kind of enabling us to do so. Participation in various rehabilitations, physical activities, exercises would be more accessible if those funds are available, more accessible to people who cannot afford them at the moment, or the patients that cannot afford it at the moment. The participation of the Serbian health system would enable spa treatment for a larger number of patients, but that is not happening because it's kind of difficult to organize, and those spa treatments can be quite expensive if they're financed from our own pockets. If personal finances allow, caregivers or patients can hire additional help because obviously I'm not able to cover all the needs of my wife and her present state. So sometimes we're hiring additional help. However, if this is not the case, the caregiver's burden increases more and more, and it's becoming the position of both the patient and the caregiver are becoming more and more difficult. The workload of the caregiver depends on the mental health and motivation of the patient to remain as independent as possible, and on the will and motivation to be useful to his or her family, regardless of the limitations which PD brings with it. That is also another aspect where we have differences. Some of the patients are giving up kind of hope, and in those cases that the association can be very useful in bringing them back together or taking them so that they can engage again, either in the society or in some activities which are going to help them both mentally and physically. Attempts to provide disabled status or assistance in care or a parking space for a vehicle for patients in an advanced stage of the disease is not did not meet the positive response from the healthy care system of the Republic. In other words, they don't understand the degree to which the Parkinson's disease patients in the advanced stage of the sickness are affected by and they sometimes those commissions don't even realize that there is no cure, that the illness is only progressing, never diminishing. Also, caregivers spend a lot of time looking for some important drugs. At the moment, we're talking about Azilect and Madopar HBS, which are currently not on the market for most likely formal or bureaucratic or whatever other reasons there are. It is also not clear whether these drugs will be canceled, whether their replacement will be introduced, or they will reappear on the market, or if they return on the list of drug financed by the healthcare system. So lack of information is there. We are trying to overcome them, but it's going with difficulties, to say the least. Okay, that's about it that I had to say, and that's all. Thank you.
Thank you.
Thank you so much, Ivan. I think, I mean, we are from Asociación Parkinson Madrid, so we share all those worries that you were talking about. So it's like a manifesto, all the things you mentioned about the lack of information and all those worries about everything, treatments, funding, and so on. So thank you very much for your approach. And more being as a husband of someone with Parkinson's disease, you know quite well how it is to live with this disease. So maybe we can proceed with Vladana Markovic, and then maybe at the end we can share some opinions or make some questions, and that can enrich the good practices. Thank you. Vladana,
And Micah, please talk a little bit louder next time, please.
Sorry?
Can you talk a little bit louder next time, please?
Okay. I will.
Okay.
Thank you, Sasha.
Okay.
Hi, hello, good afternoon from my side too. I hope you can hear me well. So my topic is to discuss a little bit about research of Parkinson's disease that are currently being conducted at my department. I work at the Department for Movement Disorders here at Neurology Clinic in Belgrade. And we actually have quite lively scientific activity. So I chose my favorite field here, and I would like to show you how we managed to implement some of our findings in research, in our clinical work, through the prism of impulse control disorders. And as you might know, impulse control disorders were quite a novelty over the last decade in the field of Parkinson's disease, and a lot has changed over the last 10 years. So it was recognized that our PD patients suffer more commonly than it would be expected, from this very heterogeneous group of disorders that are characterized by failure to resist impulse, drive, or temptation to perform activity that is harmful for that patients or others. And actually what we can see in Parkinson's disease is different from that we see in general population. So our patients classically present with pathological gambling, hypersexuality, pathological eating, and compulsive buying, while in general population you can only see pathological gambling here in DSM-4 classification. And interestingly, it is changed now in the newest DSM-5 classification, where pathological gambling is actually classified as one type of behavioral addiction, which you, as you might consider, also is actually more accurate than the previous classification. So what we see in our patient is very, very diverse, and one might say, does it even make us a same disease? Is it the same problem? And these four major ones are classified as major ICDs. And what was even more interesting was that we actually found that our patients have some different behavioral changes that were quite peculiar, such as pudning, and I will talk about it a little bit later, and also dopamine dysregulation syndrome, hobbyism, hoarding, and all these behaviors are now classified as impulsive compulsive behavior spectrum of the disease. So more than 10 years ago, when it first came into focus, we thought that up to 14% of all PD patients have these disorders, but currently we know that it is a lot more. So these are the first studies that were conducted from 2008 to 2010, where we can see about 13% of patients in USA compares to only 3.5% patients in China. So it was thought to be maybe tied to Western Hemisphere. But new screening instruments were developed, and these new screening instruments have discovered that it is actually a lot more common. So through our work, we now have these instruments also translated in Serbian language. And now we know that the frequency is quite similar around the globe, and it is about 30%. So almost 1/3 of all our patients have at least one of these disorders, and the preference for different types of disorders is a little bit different. It varies across the globe. So, for example, Italy and USA have higher incidence of pathological gamblers. These countries more patients with hypersexuality, and here in Serbia and Turkey, for example, and Mexico, we have punding as the most common disorders. So this is why I want to share a little bit more about it. So it is a very complex stereotype behavior characterized by an intense fascination with repetitive activity, which is devoid of content. And even when it is seemingly goal-oriented, it does not lead to obtaining a reward. And so this is a paper by my colleague from my department and his collaborator from Italy and now Toronto, where they propose criteria and funding rating scale as well. So what our patients were doing, and we saw many interesting things as our research was continuing. So we saw patients that were interested in repairing and crafting. This patient is bringing his barbecue device. So this is the patient which was sewing and drawing. So she brought many books with her drawings here to us. This is the patient who was actually police officer, retired due to PD, but then developed an intense fascination with making furniture. And here in the photo, you can see that he actually lost a finger while performing these activities, and that it can also be quite dangerous. You can see this patient who is very fascinated with household repairments. He actually does them for all his neighborhood, and he's as you can see, the light is on, so he's actually quite endangered here in these photos. Also, you can see some patients interested in bird breeding, in collections of different photos and albums, so sorting. So it can be quite simple, like these patients with sorting, but also very, very complex. So all type of activities can be involved, and it usually depends on the previous interests of that patient and the premorbid interests of patients. So why is it happening was our main question, and we tried to look for some specific answers and try to realize which patients will be prone to developing these disorders. So now there are many studies looking into the factors that can lead to such disorders, and we know that there are some demographic ones, so like country of origin, some gender-related factors, and also younger age. This is really important, that younger patients are more prone to these disorders. Those with earlier disease onset, and some specific treatments, and I will come back later to this. So also some premorbid traits, such as positive personal or family history for addiction disorders or for gambling, some impulsivity and novelty seeking as personal traits, and also genetic predispositions are being currently investigated. So we were actually interested in neuroimaging correlates for these behaviors, and different levels have been postulated to be at fault here. So some changes in the dopaminergic system, ventral striatum, and frontal cortex have been considered. And such findings we have shown in our studies, and I will not go here into details. I just want to show you a couple of papers that came from our group in collaboration with colleagues from Milan. So this was a large group of patients that was investigated for different types of impulsive compulsive behaviors, and we show that they have some specific patterns of cortical thinning and also different types of resting state fMRI connectivity that was underlying their behaviors. So it actually had some structural component or functional component to that. And then as I mentioned, so since panding was the most common type of behavioral disorder here in our population, we try to focus more on these patients specifically, and it was this paper that was published in Neurology a couple of years ago, where we showed that actually patients with panding have specific frontal cortical thinning and also changes in the functional connectivity of some subcortical structures with subcortical hyperconnectivity and hypoconnectivity to cortical inhibition centers. And this was in particularly true for habenula and amygdala nuclei. And I will not bother you too much with that. And also even some white matter tract damage was involved here, especially to the frontal parts, the genu of corpus callosum. So where we can see that even some specificity, some reasonable specificity was obtained in differentiating between patients with panding and those without. But actually, what brought us here was to circle back to these correlates that are demographic ones. And actually, in the last couple of years, unlike these studies that were cross-sectional, two longitudinal studies actually were published. And this was the first one by a French group in 2018, where they showed 4 times fold increased risk with dopamine agonists use. And actually, this was the only risk factors from all these that are mentioned here that was pertained as important in a longitudinal manner. And 2 years later, our group actually confirmed this finding, and this is the paper at our department. You can see me and our host today, Dr. Radovanovic, here among authors. So we show that actually dopamine agonist treatment was the one that was a predictor of impulsive compulsive behavior disorders occurrence. So this has led to significant changes in clinical practice. And here I want to show you guidelines for treatment of Parkinson's disease from 2013 and 2018. And you can see here that actually is mentioned that the choice of drug that will be the first drug when the patient start treatment will depend on the impact of improving motor disability compared to the risk of motor complications. And neuropsychiatric complications that are here considered to be mainly dementia. So impulsive compulsive disorders are not mentioned here at all, even though there was at least 5 years of intense research at this point in 2013. And also it is stated here a particularly problematic thing that initial treatment with an agonist can be recommended in younger patients. And it was a good clinical practice point. And as you remember, I said that the younger age at disease, of patients and younger age at disease onset is actually a major risk factor for these behaviors. And this other review from the International Parkinson and Movement Disorder Study Group published in 2018 says that dopamine agonists are clinically useful and that there are no additional safety concerns at this point regarding these medications. But this has all changed here in the latest guidelines. So these are American ones. European ones were not published since these two that I have shown you. So 2 years ago, American Academy of Neurology guideline subcommittee published guideline for dopaminergic therapy for motor symptoms in early Parkinson's disease practice. And you can see they are citing these two studies that I have just shown you, ours and from the French group. And based on our these two studies, the guidelines have changed, and we are happy to see that, because we feel that it really leads to improvement in care for our patients. So you can see here that it is stated clearly that it should not be prescribed to patients in risk of impulsive compulsive behaviors, and this is the first time that these disorders are mentioned actually in clinical practice guidelines, and these ones are especially important, I feel, and I would like to point out on them. So you see several things. So it is stated that clinicians should inform the patient and caregiver of the important effects of the dopamine agonists before prescribing them, and that this should specifically include impulsive compulsive disorders, impulse control disorders here in the first place, and also some other important ones such as sleepiness and nausea, postural hypotension, and hallucinations. And not only that, but also that the patients should be screened for these disorders prior to starting a dopamine agonist. Then that patients should be regularly screened for these disorders at each consecutive visit. And also that it is not enough to talk only to patients, and we have seen a lot of this, including clinical practice, actually patients denying that they have any problems and only interview with a caregiver revealing severe problems, so that these patients should be assessed not alone, but also we have to include caregivers and question them about specifically impulse control disorders. So, sorry, it skipped a bit, and I will just circle back to my last slide, and it's here. So I feel, and I hope you will agree with me, that this is a nice example of seeing some problem and clinical practice while doing our everyday work, helping our patients, then noticing some real-world problems, conducting research, and then finally going back from research to treatment recommendations, which will eventually improve actually our clinical practice and improve treatment options for our patients. And with that, I thank you for your attention today.
Okay, thank you, Vladana. Thank you so much. So now maybe it's time for some questions. I don't know if you want to start, any of you? If not, I have a question for Vladana and for the others also. But yeah, just when I saw about the difference, the cultural differences, I mean about the impulse control disorder, you said that in Italy and USA the rates were higher. For instance, in some of the cases. What is the reason behind? I mean, is it because in the clinical practice maybe there are more dopaminergic agonists being prescribed, or what is behind that? Because I don't think they are younger. I mean,
no, actually, this is the question that does not have an answer yet. So I can maybe try to share some of my opinions. And actually, I believe that there is a thing in that that we mentioned, that there is some effect of pre-morbid interests, and that they may vary geographically. So maybe that is also the question of availability of different things. So you won't get pathological gambling in the countries where it is forbidden legally, of course. And also if you think about some economic things, like here in Serbia, we have quite low standards still. So it's a developing country. So you can't expect patients to have actually a lot of money to start with gambling. We have gamblers, of course, but it is not as dramatic as it can be in USA, where average loss was about $40,000 per patient. So it's quite a lot, and it's not something you can see here. We have more of the sports betting here, more than gambling. So it's not such a big problem, but actually for some reason it was Punding that was here. Probably it's more available, it's easier, it's not that expensive. I think there are some economic reasons to this as well.
Okay, yeah. Yeah, then when you were saying, I mean, the last, your last images, when you were saying, I mean, the patient should be in the center, for instance, with all those symptoms in Asociación Parkinson Madrid, we are trying to help patients and caregivers to identify this type of symptomatology, because it can be, as you said, so much related with medication. So we have a program where we make an appointment with patients and caregivers a few days before they have the appointment with the neurologist, so that we present them a list of symptomatology that it's not so well known sometimes, so that they can identify and then provide some feedback to the neurologist about this. And we are trying to include that list in an app. So it's, I wanted to ask Ivan if you have something similar in your case, if you can, in your society, to help patients and caregivers related to this with the impulse control disorder that sometimes is not so well known. I mean, yeah.
It's a great point.
In my experience with my wife is not a gambler, luckily. She's not even betting, but what she's doing, and it's kind of driving me nuts sometimes, she's moving paintings around the wall, constantly changing the position. Another thing is in the kitchen, she's all the time moving things around, relocating things, and I have problems finding them. But I take it as it comes. I mean, there is nothing. She just say, I had to do that, and that's it. So I'm not making an issue out of that, and I accept it as it comes.
Yeah. Yeah.
That's my only experience with that. Luckily, with other things, we don't have any problems.
Yeah. We have some of our members that they paint a lot as well. So we create an exhibition. I mean, we have in the main corridors of the association, if you see our walls, we are always with some new paintings there, in order, to use all that creativity also, and have some positive side from this. Yeah. I don't know if
we had a similar World Parkinson's Disease celebration like before COVID, so where we actually had our patients bring in their works of art. It was really, really interesting. Yeah, I didn't include it now, but I have it in some of my lectures. So it's really a nice thing, unlike these that can be quite terrifying. Yeah.
I don't know, for if you have any questions, just raise your hand. Otherwise, I wanted to ask Gorica. You were saying about the quality of life of people with Parkinson there, and I don't know if I understood properly. There were no differences between men and women. Is that correct in the first presentation, the first part of your presentation?
Yes, we didn't observe gender-related differences among quality of life and SF36 domains, but maybe we can address some other points such as comorbidities and non-motor symptoms as we observed in our research. So those are maybe key points to address in the future in order to improve their quality of life, because we saw that motor symptoms are not so significant for their quality of life, yes, in comparison to other symptoms.
Yeah, that was my question, because I was reading about
Yes.
non-motor symptoms like
Yes.
depression or anxiety in women that are more frequent than in male, and also that the risk for developing Parkinson's disease is higher in men, but then the progression can be faster with a high mortality rate in women. So I was just trying to get connected about how quality of life can also be affected. So
Yes.
yeah. And this is a question for all of you, because in this project in eCare for PD, we are also trying to think about how technology can improve the quality of life and the life in general of people with Parkinson, caregivers, and so on. I don't know if you know any any services or any good practice cases where the use of technology have helped to improve this somehow.
Well, actually, it was useful, especially during COVID time, because we used some telemedicine for our patients for performing controls in the time when we weren't able to do on-site visits. So it was really useful. We used actually Zoom. We used even WhatsApp, Viber calls, so to assess our patients and to help them over this time. So this was useful, but actually, I think we should think more about how to keep it now when we are going back to the normal functioning. So this is really good point. So to consider to include more of these into our everyday work now that we are back to normal. Thank you.
Yeah, because in our case in Asociación Parkinson Madrid, we also started with telerehabilitation service during COVID. But now it's true that I don't know, but people prefer to go face to face to attend to the local. So it's been difficult to keep on with that service somehow. So we know it's useful, but we need maybe to study a little bit more the target group.
Just a short info. I will be in a better position to give you an answer about new technologies in about, say, a month time. My wife is scheduled to try a special suit next week, which is, I think, Molly suit or something like that, developed in Sweden and manufactured by a German company. And that suit is supposed to, by electrical stimulation and other kinds of stimulation, should enable patients who do not have a very good control of their movements to improve a lot. We will see. The suit is very expensive. There are scheduled some tryouts are going to be scheduled. Three periods are going to be scheduled. So we'll see how. But that is some of the new technology, which is, I don't think it's covered extensively in the mainstream media or in Parkinson's disease media. We'll see.
What do our colleagues from
let us know.
Think about this?
Pardon me?
Is there any?
We didn't hear you, Paula.
I'm asking. Don't cover me, please. I'm asking our colleagues from the medical school. Do you know anything about this device, so-called stimulating suit? What do you think about it? Rather, you're muted.
Yeah, I noticed. So of course, we don't have any personal experience with it, but we read it in the media. It was quite a hit. So we are looking forward to hearing about the results. So it would be great innovation.
Yeah, Ivan will tell us soon.
Okay, thank you.
But it's extremely expensive.
That's what is.
We'll see.
So, Maitz, I had a raised hand for some time.
Okay, sorry, Pablo. Go ahead.
No, it was fine. I was just waiting. I don't know if anybody else has questions because I was waiting to be the last if there are no other. First, I would like to really commend Ivan Brankovan for giving us all this important information, especially about the organization, which was really very well doing here. And now there is a serious problem because the president is deceased, and she was a very energetic woman, although a patient. And really helped a lot. Actually, I met her several times, and we organized some outreach meetings where she gave a talk, and it was really amazing, all the achievements. And this is something that is definitely a good practice, and I thought that would be really nice to hear this from actually a patient caregiver. And even really gave a speech, a text, which is even on a higher level than I expected regarding the achievements. Really something I think we should put in our guidebook, of good practices. That's just to commend even for helping us here. And I would have two questions for our MD colleagues. First, maybe to Gorica. So you gave us an overview regarding the quality of life of patients in Serbia. How does that compare? Can you have any comparisons with the region or Europe or outside? Are there any significant differences when you compare Serbia to other environments?
Thank you very much. Well, there are maybe some differences, but in general, our results are really similar to other studies investigating same and using same instruments for really health-related quality of life. So our results, we can be satisfied because our results can compare to other results in the region and worldwide.
Okay, thank you. And for Vladana, I also think it could be a good example. The recommendations they've given could also be a good practice, I think, a point to put in our guide, although this is it is an international thing regarding this behavioral characterizations. But a question for you, Vladana, is your topic was about benefits. But I didn't hear much about, did you have any really study of benefits for patients? This was all suggestions or some kind of statistics and actually also suggestions of therapy. Do you have any measure of benefit yet for some of these recommendations?
Yeah, well, the recommendations are quite new. So the benefit for our patients was in the first place that we started to diagnose our patients. So these behavioral disorders went unnoticed for about 3 decades. So the first time that hypersexuality was described was 2 years after levodopa was introduced in 1969, and in 1971 was the first paper that described hypersexuality actually in 5% of patients, which is similar to the percent we see today. But then these disorders went somehow underground and went completely unnoticed until the 2010s. And it wasn't until we started to be interested in these disorders in scientific way that we started actually to diagnose them in our real patients. And those are the photos I've showed you. These things went completely unnoticed in the years before. So these medications were regularly used since 1995. So there was 15 years of people having problems and went completely unnoticed because they actually didn't know, should they discuss it with their neurologist. So this is a very, very obvious benefit. We started to diagnose these patients. We started to discuss it with them. And this was actually the point where they did have some improvement improvement, they could share it with us. They knew that they are understood, that they didn't think that there is some weird thing that is happening only to them. And even the thing that we warned them about it, that we talked to it priorly, they feel more comfortable about sharing. And of course, treatment. I didn't have time actually to put in treatment recommendations now, because I wanted to focus on what we did here. So treatment recommendations are quite clear. And it is actually stopping of these agents. You need to identify the medication that is trigger, and you need to stop it. So this is quite problematic because you can have motor worsening, and you need to have your patients monitored for motor worsening, and you have to try to supplement the motor activity with different agents. And actually now it is a very good point, and these patients are actually considered a good candidate for deep brain stimulation surgery, which is, as you know, for the last 2 years available here in Serbia. And actually 3 of our patients had very severe impulse control disorders prior to operation, and they are completely free of them now. This is, I believe, benefit, yeah. And of course, further monitoring of patients, and we have not included in this study because it was prior to change into clinical practice. We need to follow up with the further investigation to measure up how our patients are doing now with the changed clinical practice. So we will need another 5 years for that, I believe. Thank you.
Okay, thank you very much. So it's a kind of a marker for a follow-up of patients or even therapy.
It can be.
It's a new marker. Okay, thank you very much. That's very interesting.
Thank you.
Thank you. Any other question? Maybe.
So far, so good, huh?
Okay. If not, we can conclude. Thank you, everybody, for attending. This has been the last Good Practice Exchange meeting. So next thing we will do, it will be to have a thought on all the sharing experience we have been aware of, and then we will provide and we will create that good practice guide in order to give a voice to all these things that we are doing well or we are trying to do well in the different countries, and share it through this Erasmus Plus project. So on my side, anything else? Thanks again, and
Thank you,
we see
Maisa,
each other. Yeah.
Thank you.
Thank you for the organization, and I apologize for making it rather late this event, but I hope it was worth it, because I think we had some really good appearances here and talks.
We had a perfect speakers and presenters. Really,
Yes.
not.
Thank you so
With
much.
a
Thank you.
very good
Thank you,
accent.
everyone. Thank you.
Ivan, very good English accent.
Practicing a lot.
Yeah, we Serbians are like that. Yeah, thank you.
Yes.
Okay,
Thank you. Thank
bye,
you.
bye all,
Okay.
and